Toto. And tonight we are very excited to be talking about the nurses' CalCare bill, AB 1400. We have Dr. Ron Birnbaum leading tonight's discussion. And Dr. Ron Birnbaum is a physician and a progressive political activist. His clinical specialty is dermatology, and his focus has been on the care of the underserved and marginalized in Los Angeles County. He is part of the Healthcare for All Los Angeles leadership team, as well as the state and Southern California steering committees for Physicians for a National Healthcare Program. We love PNHP. He is super active in the Democratic Party. He serves on the Central Committee of the Los Angeles County and California Democratic Parties, and he was a pledged delegate for Bernie Sanders at the DNC in 2020. With that, Ron, take it away.
No, thank you for that. And thank you everybody who's here and who is out in Facebook land watching this. We're going to do a couple things tonight. So we're going to talk a little bit about the legislative pathway ahead for the bill, just a little bit, and then and a little past history, and then get into the bill itself, focusing on its sort of core values and goals, and then mostly just do questions. And we're here to do that because people have questions and we want to answer them. But also, this is sort of a prelude to a coming sort of regular activity that we're going to do on Sundays at 5, that will be a joint Healthcare for All Los Angeles, PNHP, SoCal activity that's office hours on AB 1400. The first one is going to be this weekend. It'll be Jeanna Harris and I will be the co-hosts. So the nurse and the doctor are in together on this. And but we'll be, in some ways tonight, we'll kind of give you a sense of what that may be like, and we'll model that, because we're hoping that as you all here as activists who are behind the bill, we'll see that as a tool, so that when you come across people who want to do a deeper dive, then you have the time to give them your tabling or something like that. You're going to have this place like, oh my God, you have these great questions. Go to the office hours. We'll get your questions answered. And also, hopefully, people here will be interested in being office hours staff. So more on that. But let's do it. So first, I'm going to share now. Is that okay to go ahead and share? And a little recent history, or not so recent and not so recent history of single payer bills in California. And it turns out I was involved in the very first one, which was Proposition 186, which is a ballot initiative, which came up when I was a medical student. I collected signatures for that one. That one got walloped in front of the voters. Lots to tell there. But over the years, there's been a number of bills, 2003, 2005, 2009, and then most recently, SB 562, which was the Laura Atkins bill that was introduced in 2017 and sort of notoriously passed in the state Senate and blocked in the Assembly Rules Committee by then and now Speaker Anthony Rendon. But as we know, we'll go over this in a little more detail, there has been a new bill introduced to do a single payer universal healthcare system in California. That is AB 1400, the Guaranteed Healthcare for All Act. And so let's see. Oh, okay. So this is the California Guaranteed Healthcare for All Act. The plan or the program it would put into place would be CalCare. And so some people will use those words interchangeably. This slide just shows some of the sponsors and the co-authors on the Senate side and on the Assembly side. So just so you're aware that that's all that's there. And considering right now the composition of the legislature, it is in theory favorable to the passage of this. There are super majorities of Democrats in both the Assembly and in the state Senates. And that's important in terms of passing a bill and implementing a bill, because implementing a bill involves raising taxes ultimately, and that generally isn't just done on simple majority votes in California, but needs super majorities. So, but they're big super majorities, they're kind of super majorities. So that is the legislature we're looking at. That's not to say everybody in there supports us already, and that's why we heard our political team talking about that work. So envisioning the pathway ahead, this slide talks a little bit about, well, what's ahead? So the bill was introduced and had been, the first thing it puts us a little backwards, had been through legislative council to write the bill into good language that's appropriate for its purpose, and was introduced February 19th. And its next place will be the Rules Committee, but there's already a plan in place for a hearing in the Health Committee. This then presumes that the leadership is intending to allow it to go through the Rules Committee. That's supposed to be April 21st. Now, the Health Committee has, which is chaired by a dentist from Northern California, not historically super supportive of this, but he's the chair, has taken one action already, which is to ask for something called the California Health Benefits Review Program to review the bill. That is a body that was put in place by the legislature in 2002 to evaluate new bills, mostly like smaller ball things, like a new benefit that would be required across health plans. And so this is sort of an unusual ask of that committee. And I and others have done some work putting kind of input to that committee's work and directing kind of evidence-based stuff on single payer and bills like this one to them. So hopefully they won't be harmful. I don't think they're going to be game-changing one way or the other. This then the bill then has, if it passes from the Health Committee, will go to the Appropriations Committee, and then a floor vote in the Assembly, where if it passes, it has to happen by June 4th to get through this cycle. Then it'll go through a similar sequence in the Senate, and to be passed in 2021 would have to be passed by the Senate in September and signed into law by the governor in October. So that is what's needed to pass the bill. That's not all of what's needed to actually implement this. And there may be different views about all of what would be needed to implement, but certainly necessary, but not sufficient. So it would require the passage of the bill, the application for and receipt of waivers from the federal government to allow the redirection of funds that the federal government spends in California on healthcare, such as in the ACA and in Medicare and Medi-Cal, which is Medicaid in California, and the SCHIP, those programs, to redirect those monies into the CalCare trust fund to make it a single payer. The recent confirmation of Javier Becerra is probably favorable to that. He at least understands the issues and has signaled his support for single payer in general recently. Then people who've read the bill carefully know that it doesn't include its own tax program. There would have to be a separate tax program passed or amended into this bill earlier in the process. And then finally, the Secretary of Health and Human Services of this state, who right now is a guy named Mark Galley, would have to affirm that the trust fund has the dollars it does to launch the implementation of the bill. So that's sort of the path ahead. And so then let's go on to the bill. And I'm going to just lay out some of its main principles, and then we just want to take questions. And so there'll be more opportunities for this will have some deep dive opportunity and more in the future. So let me just quickly run through these core kind of things that the bill puts in place. So one is it covers everybody. And there's really nobody who's excluded. There's minor issues about things like if you're a college student from out of state, or how long you have to live in the state to be kind of considered a resident. Some of those things are addressed in the bill. But that stuff aside, it's about everybody, including irrespective, for example, of documentation status, which that would be a major change in California and in any state to cover all the undocumented. They're a huge chunk of our uninsured in this state. This bill is a true single payer program, which is to say that it essentially it eliminates the ability of other payers to duplicate the coverage of the bill. And so it's a real, as I would say, God-fearing single payer program. It has full benefits essentially by any standards in what's described in the bill, and including, and sometimes people will use the words Medicare for all to talk about single payer, and there's some good reasons to talk about that. But as Jeanna Harris is a frequent sort of teacher on this topic, Medicare has some problems and certainly doesn't cover all kinds of important things, like a lot of stuff from your neck up, like hearing, vision, and dental care and other things. But this bill would. It essentially ends narrow networks. It ends networks. More or less everybody who provides healthcare in the state either has to decide to participate or only essentially do cash stuff, which would be very few people who we think would do that. It also eliminates cost sharing, right? So it eliminates things like copays and premiums or deductibles. So people pay taxes, but at the point of care, when you need care, there is never a financial barrier to that care, zero. And that's very important, because actually financial barriers to care have been studied, and while they sometimes lower a little bit of unnecessary care, they mostly prevent necessary care. And they don't do a particularly good job of saving money on the whole. There's other the drivers of big healthcare costs are not primarily patient-driven overutilization. Let's just say that. The program knows and acknowledges that healthcare is 20% of the California economy. There are a whole bunch of people who are employed in billing and insurance company stuff. Many of those jobs would of necessity disappear. And that's not a trivial matter, because progressive legislation always cares about who is hurt the most by the legislation. And the bill envisions then a just transition so that those folks can be taken care of through a combination of retraining and things like expanded unemployment benefits, although it isn't totally specific yet on all the details there, but it certainly anticipates those issues. And then finally, it describes a system that's based on patient need and not primarily financial incentives, especially negative financial incentives to care. So it ends things like value-based payments and capitation arrangements, which are important parts of HMO structures and that kind of thing. And those are features that even the sort of purest believers in what single payer means, it meets their criteria of this bill in ways that we haven't entirely seen before. So that is the bill in a nutshell. And so that's our plan is let's take some questions.
Yeah, so in taking questions, if you are on Zoom, go ahead and drop any questions you have in the chat. And I just want to do a check-in with Jason Small. Are you on Facebook, Jason?
Yes, I am, Madam Chair, and there are no questions at this time.
Okay, great. As soon as I put this out there, I got flooded with questions. So I actually have enough questions to last us the whole night. So what I'm going to do is I'm going to go ahead and start asking these questions, but I will keep my eye on the chat. And so if somebody puts a question in, I will move to chat. And Jason, you can just interrupt me if you get questions from Facebook, okay? And just a reminder, these are questions about the bill tonight. So, okay. Dr. Ron, first question. How will CalCare address the high cost of prescription drugs as it is mentioned in the Legislative Council Digest? Is there a strategy?
Yeah, that's a great question. And it actually
That's from our dentist friends.
no, thank you.
Sarah and Omer,
The doctors, Dean.
the doctors.
No, thank you for that question. And so actually in the history of single payer bills, and I would refer you guys in particular to a paper in PLOS Medicine 2020 by Jim Kahn from UCSF and others. So single payer bills on the whole save money. And when they've been studied carefully, and also if you look the world over, they also save money. And actually one of the number one ways they save money is in prescription drug costs. And the way that is achieved is through the monopsony or the bargaining power of one consumer or one payer of or purchaser of drugs. And so that is a very powerful thing. It and it's so powerful that if you've ever followed the politics of drug prices in the United States and seen that people who have hoped that Medicare could negotiate drug prices with the pharmaceutical companies, well, the pharmaceutical companies have always lobbied viciously to prevent that, including paying Democrats and Republicans to sort of torpedo that, because they know that when the collective purchasing power of the public is deployed in negotiating drug prices, that they will go down. And that is true in other places in the world. In other words, it's not merely economic theory, it is in practice in other places. And we can do that too. We are a big market. And that's the answer.
Thank you. I do have a question in Zoom from Isaac Lieberman. He said, you said it, meaning the bill, quote, envisions a just transition. Does it guarantee or at least fund just transitions?
Yes, thank you. It does. So one thing is that the bill it doesn't talk dollars. There's no part of this bill yet. It talks about the different funds, sort of different sub-funds within the trust fund, and that's one of them. But it also says that money will be routed through another department in the state, which is essentially the labor department. But I'll also say that, in particular, the CNA, which is a union, is particularly attuned to this issue of job displacements within the world of healthcare related to this. So it doesn't specify a dollar amount. So let me just say that, if that's not in this bill. Yeah.
Okay, thanks. I'm going to go to another question that was emailed in. We are concerned that CalCare board members and committee members can serve for an unlimited number of terms. We see term length limits, but unlimited terms.
So that's correct. What it says is that you can. So we didn't talk about the governance structure in this because this is a big overview. So let me just give a little quick background to that. The plan will be governed by 9 people. There's a board that's 9 people. And then there's 2 a commission and an advisory committee that will provide them advice. But the actual sort of authority is in 9 people. And the bill describes who gets to appoint those 9 people. They come from the governor, and the 2 bodies of the legislature. And then it says who's who, and it also sets some terms. The general terms are 4 years, although there's some special one-off term lengths at the beginning to make sure that the boards, it's kind of staggered. So the whole team doesn't sort of disappear all at once. So initial terms are 2 years for some and 5 for others. But then the steady state would be 4-year terms. And you're absolutely right that that there's no specified term limits. And let me just say this too, which is that I think those are very legitimate questions and should be points of debate in the legislature. In other words, we're talking about turning over 1/5 of the 5th biggest economy in the world to the general control of a group of 9 people. That will be a source of political debate, well, let's just say, and I think is a real concern in the issues of democratic governance with the accountability of that group of people. And so your question is correct. I guess I'd say I share your concern, and that would at this point require amendment of the bill, which is a legitimate thing to be out there thinking that it should be done, to say that the bill should be amended in certain ways. In other words, I'm not here, I do want to describe what's in the bill, and I am absolutely a supporter of this bill, but that doesn't mean that it can't be improved. And I think you've hit on one area, in my opinion.
Thank you. I have a question on Zoom from Paul Newman and then Isaac Lieberman. It's very similar, so I'm going to read them both. So Paul Newman says, what percentage of state tax charged to the citizen? And then Isaac says, you said I'm going to get taxed, just what I need. I'm already taxed up the wazoo and I can't afford, and I don't deserve to be taxed more. Is AB 1400 going to cost me more money?
So first I want to thank Isaac for this question for many reasons. We all owe Isaac many debts of thanks for his activism, which is tireless. And so one is that I know what Isaac thinks, which is he's a diehard supporter of this. What he's doing with this question is he's, as an activist, he wants to be able to kind of answer the undecided folks' question in ways that he will anticipate they'll be asked. That is absolutely one of the goals of this and the office hours thing. It's supposed to answer the questions of the undecided, answer the questions that the activist knows they are hearing or will be hearing or have heard from the undecided. So let me say 2 things. So currently, we already know, based on really good study that was done just a couple of years ago, that 70% of dollars spent on healthcare in California already are government dollars. And so that's item number 1. Item number 2 is that everywhere in the world where there are universal healthcare systems in place, the totality of that polity as a percentage of its GDP spends less and not more on healthcare. And so, but the way that this right now, we spend in a lot of different ways. We spend through taxes. Already there's large taxes. And then we also spend in the form of direct payments to healthcare providers, premiums, co-payments, deductible payments that are deductibles, and co-insurance, and out-of-pocket purchase of things like prescriptions and all kinds of things. So when this bill gets enacted, there will be taxes, and there will also be the disappearance of a whole bunch of other things that people pay for all the time. So while your taxes, some people's taxes will go up, all of these other things will go down, and we know that everywhere in the world where this is the case, the net of that is money in your pocket, not money out of your pocket. Now, we're progressives, and it should be a progressive taxation scheme. That means the incidence will fall more highly on wealthier people and corporations, depending on how the taxes are structured. We know that that's how the tax program would go. We know how the tax program that had been proposed for SB 562 would have done that. But so how any individual would shake out depends on the tax program and their current tax status and what they're paying out of their pockets right now for healthcare. Also, there's invisible taxes in all this that we don't know. In other words, if you look at wages in the United States of America, which have been incredibly stagnant, and then you compare that to health costs over the years, and you want to know where the wage increases have gone for decades and decades, they've mostly gone to healthcare inflation costs and to the people who profit off of healthcare. So I think that this is going to be a financial sort of explosion in a positive way for California and Californians.
Yeah, thank you so much, Ron. I always like to say too, my simple thing is think of it as money in your pocket and money out of your pocket. So I really appreciate that you hit that. And I mean, just rename premiums, deductibles, co-pays, taxes.
Right.
So let's not get, it's money in your pocket, money out of your pocket.
Right.
And there's more money in your pocket with single payer healthcare. Okay, so I am going to go on to this next question here. We are concerned that there is not a health equity officer position outlined in the governance of CalCare. Social determinants of health must be meaningfully addressed. What you got to say about that?
No, that's a great question. So I will say what it's sort of, I think it's a little, I disagree with the comment that it's a little thin on that. I don't think it's that the nurses have not, in the writing, have not anticipated it. The most important way that they have anticipated that is a little bit subtle. If you look at the funding streams that are described within the trust fund, one of them is the special projects budget. And the special projects budget is about doing investment in capital and operating expenses and even differential payments to places where health people have been underserved, which is primarily rural areas and the urban underserved in California. And so it absolutely does anticipate that, but I think that it should be strengthened in that. And some of the people on this call and I have also been involved because we didn't know that there was going to be a bill coming out. I've been in a long-term project of writing a single payer model for California. And we certainly have envisioned a much more robust kind of attention to those equity issues. And so I think those are legitimate criticisms. And it's not that it's absent, but that it should be more explicit and strengthened in the bill. Those signals are drivers in where we send the money, because the truth is that we've starved whole areas, and people, frankly, primarily the poor rural people in poor rural areas and people of color in the state. And one other thing about social determinants, it's a great point, because insurance is not entirely what determines healthcare outcomes, and it is the case that social determinants of health are important to healthcare outcomes. It is also true in essentially everywhere in the world that has single payer systems or universal healthcare systems in place, that they spend less on healthcare and more on social investments. So on healthcare, housing, on sort of education, housing, and other social investments. Now, this bill doesn't guarantee that the state will do that, but that is the way. I think that is fundamentally the way, or one of the trade-offs in countries that have better healthcare outcomes, is a combination of universality and better investments in, as you said, the social determinants of health, or things which improve the social determinants of health.
Erica, if you're talking, you might need to unmute.
Thank you. Okay, I have a question from Carol Fodera. In AB 1400, there are conflict of interest provisions for board members. Quote, the board shall hire an executive director to organize, administer, and manage the operations of the board.
It's not a question. It was just a comment.
Okay, fabulous. That's a wonderful comment. Do you have anything to say about that comment, Ron?
Yeah, well, it's interesting. And yeah, I certainly noticed that. And look, when we're talking, and we will continue to need to be both thinking about the governance of this, because when you put a lot of power into, even if it was a more expansive board and had more different checks on it, we're still talking about a lot of power, and therefore a lot of potential. When there's a lot of power and a lot of money, a lot of potential for corruption or influence. And so I think that the ethics of who are on those boards, I mean, the ethics of people who are making decisions about formulary always have to be, extremely tight, right? And so I think that's right. But it's also the case, one thing that's kind of interesting is that quite a number of things of entities in healthcare in California that have been for profit won't continue to be able to operate that way. And that may therefore start to change some of the dynamics of the ethics of the people on the board. So we'll see. I mean, there's still, for example, will be a pharmaceutical industry, and there could be conflicts. I mean, I can't imagine how you could be on the board of a pharmaceutical company and the executive director of this, or on the board of this. I think those would clearly be in conflict.
I have a question from Betty Dumas Toto. How will this affect people on Medicare?
That's a fantastic question from both a policy standpoint and from a political standpoint, because and especially when you say the word, you just say the words Medicare for all, and somebody is on Medicare, they may look at it and say, well, I already have it, so how does this help me? And that's a great question. And actually, while I can answer this question in detail, and would love to, Jeanna, do you want to answer this question? Because this is the kind of thing, this is like a Jeanna wheelhouse question. She's answered this many times for many people very well. Would you?
Sure.
I didn't put you on the spot.
Yeah, that is actually a really good question that I think people with Medicare would ask, or Medi-Cal or CHIP or any of this. So we're taking all of their benefits and all of that money, and we're putting it all together, and we're just smushing it together and making one big healthcare baby. And that healthcare baby is going to cover stuff that Medicare doesn't cover, like your teethies. Shout out to dentist Sarah Dean on the call. Our elderly suffer so much from poor dental. Their teeth rot out and they can't even eat, and then they lose weight, and then it's a downhill slope because Medicare doesn't cover it. But Medicare will cover someone to go and do a big old oral maxillofacial surgery under general anesthesia in the hospital. Why? I do not know. So that's the answer, is that it will cover actually more and take you out of the Medicare donut hole when it comes to prescriptions, help you with your eyes, your ears, your vision, everything from the neck up that Medicare doesn't cover. So that would be really the simplest thing, is that actually you're going to get more coverage. Medi-Cal patients are treated like crap. Because they have their payment system is the lowest. So you have your PPO insurance, which is about close to the same as Medicare. And then you have Medi-Cal rates, which are way down here. And so no providers really want to see Medi-Cal patients because they know they're not going to get paid as much as the PPO or the Medicare patients. So Medi-Cal patients now get lifted up into this world where they can see quality providers. So that's where it's just like a smushed baby, and it's going to be beautiful, like just a lovely baby. And like Chang Sim just said, long-term care, just sorry to add on that, long-term care is something Medicare will only cover 100 days of skilled nursing care. And when I say skilled nursing care, I mean like you have to be getting some type of therapy or treatment. If you just need long-term care because you've aged and you just need care, guess what? Medicare doesn't cover that. You need Medi-Cal. So now, guess what's covered? That long-term care is covered without the copays. Medicare has a lot of copays that come with long-term care, mental health coverage too. So that's why this is going to be actually a lot better than each of them separate, because it actually combines, because Medi-Cal has more mental health than benefits than Medicare, but you mush them together and make those rates all the same. Now people are treated equally. You're no longer thrown to some crappy clinic because you have Medi-Cal. So that's a long way of saying you'll get better treatment.
God, thank you. I'm so excited we're going to be the team to launch the office hours things together because of awesome answers like that and the knowledge that lives in that head. I want to throw one thing into too, which is that I could anticipate being an issue for people on Medicare. And that is that if you're on Medicare, you currently also have potentially big cost sharing, like there's premiums for Medicare, and there's, and cost sharing, like co-payments, depending on other things. There's a bunch of details in that. So people have to pay money. There's a lot of out-of-pocket stuff still happening from Medicare. That said, people on Medicare may also feel like, well, okay, I paid taxes all these years, all my life to have my Medicare. And then there's going to be this new plan. And depending on what the taxes are, that could have some impact on people on Medicare. For example, the tax plan proposed for SB 562 had a sales tax with a lot of it exempted stuff, and then a gross receipts tax. So gross receipts was a tax on businesses, big businesses primarily, but sales tax potentially could have some incidence on people on Medicare. And so it's going to be important, I think, for even if the tax bill isn't out, that the tax plan come out in the not too distant future, and people be able to have an honest conversation about those things, which is, are you going to see some things go up and some things go down, and how's that's going to net out?
Can I just really quick, I saw Betty throw something in the chat about Medi-Cal and possible garnishment of wages. And there is a provision in Medi-Cal that does, but mainly it really directs property. And unfortunately, it's more towards the senior population than the younger population. So Medi-Cal, for a very high level overview, Medi-Cal has a provision that talks about what they consider property, what they consider like non-exempt property versus exempt property. And if you have too much of the non-exempt property, for example, you have more than $2,000 worth of savings, you have to spend that down before you can qualify for Medi-Cal. So if grandma really needs to be in that nursing facility and she has $10,000, you have to figure out a way to get rid of it or spend it down or transfer it or something before they'll qualify her for Medi-Cal. And the problem is that, well, why can't you just pay for health, like for her to have a caregiver? Then, well, that $10,000 will be out in probably 2 or 3 weeks. So that's the ugly side. There is a property provision, just really high level. It's really ugly. I don't like it. And we deal with it every single day in my role, trying to get people qualified for Medi-Cal so that they can stay in nursing homes. And this is something we run up against every day.
Right. In other words, the failure the system we have for long-term care is so bad, and this is a comprehensive, at least funding solution for that.
Thank you so much. And just a quick personal story with COVID. My dad got COVID, and he was in the hospital and combined hospital and nursing home for 2 months. And he was on Medicare, and you think that Medicare will cover your nursing home costs, but it does up for a certain amount of days. And after that, you have to pay out of pocket. So so everything you said, and then they kicked my dad out right when we reached that number of days. We were fortunate that we had family he could go to, but just saying, everybody does better with single payer. Okay, I have a question here from Linda Bassett. Many Californians are concerned about costs of the undocumented population. Won't giving everyone health care cost us more and increase immigration?
So, well, would it cost us more than not covering them? Yes. Is there an ethical imperative? Well, actually, it's complicated, because obviously people who are undocumented brothers and sisters and siblings also spend money in a whole bunch of ways on healthcare. Out of pocket, we have programs that, for example, Medi-Cal already covers undocumented children. Los Angeles County has a program for coverage, a bad one, but it pays for some stuff for the undocumented in the My Health LA program. We have a requirement that anybody who shows up in an emergency room get cared for. So if you deny people coverage, but they show up in an emergency room, they have to get care. So the costs of unreimbursed care in the emergency room usually gets cost shifted into commercial insurance health plans rates and other sources. And so also, for example, the federal government provides subsidies to federal qualified health centers to be able to take care of the uninsured, which includes the undocumented. So the fact is that there's already the undocumented themselves pay taxes in various ways. They also there is healthcare spending from government on their behalf. And all of that is a hodgepodge of poorly conceived programs with a lot of red tape, eligibility determinations, and a lot of like bad things. So I actually think we will save money on the undocumented population by insuring them all. I can't prove that with math. I sort of roughly believe that. Good question for like health economists to really look at that in detail.
And just to say, Linda chimed in, sounds like this will be less expensive and better care, right? So.
Yeah, I mean, just to add to that, so when you are undocumented or uninsured, I mean, it's kind of like uninsured, undocumented, same. I mean, it's kind of like neither one of them are getting care. You have people, there are doing manual labor. You see it, they're doing, gardening, and they're out doing construction. I've seen literal people who get one little cut. That cut, they try to treat it because they don't have insurance and all that stuff. They end up in the hospital getting their foot amputated. Now, what's more expensive? Having someone now that we're paying disability for the rest of their lives, or, just treating that infection when they could have gotten it treated when it started looking a little bit weird. So that's how I turn that question back, because you get a lot of conservative people who are going to ask that question. And I'm like, if you think that not covering them people, that's actually a very, very liberal of you to want to spend that so much money. Because, I'm trying to save money by treating their little infection versus having to pay them disability for the rest of their lives.
And when you get into at least the sub area of infectious disease and that kind of thing, it does it matter where you get your tuberculosis from? Is it from it's a documented or undocumented person? Doesn't it make sense for all of them all of people who have tuberculosis to get treated, because the organism is the same when it flies from that person's mouth into yours. And so, yeah, all true.
And I think COVID has really shown our neighbor's health is our health.
Yes.
So, okay, so I have a question that was sent in earlier. We appreciate that the bill identifies long-term care as an area of necessary focus. We feel that the commissioner's role and definition should be more clearly articulated. I guess maybe that's not a question, but a comment.
Yeah. No, I mean, that I think, I think the governance questions, that's one. So let me just say that it envisions that commission is essentially advisory still to the board. And this would be the commission that looks at long-term services and supports. And I mean, like, long-term care is a really big deal. It's a complicated area of policy. And I'm not positive that the bill nails the governance of that correctly either, which I don't think is a reason to oppose the bill. I think it may be a reason to amend it or improve the bill. Also, it is impossible to imagine that every known healthcare problem in California will be solved in this one bill. And in other words, like, this will not be the end of legislation in California, but it will be important. And so some things I think need to be thought out ahead of time. And I just think it's a well taken point, that should be looked at.
Here's another question. We touched on it a little bit earlier when Isaac brought up the just transition. So this question is, the just transition outlined in 100615. Will healthcare execs be able to take up those resources? We hope not. But it is a question.
Well, that's really funny though, because I don't think it's. I have to look over the the details of that again, to be honest. And you know, I mean, we're all new to this bill. I mean, I've read it a couple times in bits and pieces, a little more than a couple times, but in one of the, you know, we'll just be continuing like reading and getting smarter and reading and getting smarter. The kinds of things that were like have been in just transition parts of single payer bills have been things like job retraining and extended unemployment benefits. So that may not be super important to a health executive for Aetna or something making $20 million a year or whatever they make or more. Like, so I think we neither need to worry too much about their well-being, nor taking very deliberate actions to spite them just because that would sort of satisfy some kind of desire for sort of, I mean, this is, guys, my opinion, which is, I think there's energies better spent on affirmative good things.
Can I add to that? Because this actually directly affects me. And I was actually very happy to see that because I work for some people. And so I work for people. And in CalCare Pass, my role will disappear. And that means I would be directly affected by this. Am I worried? No, I'm a nurse. You know, but the thing is, yes, could we see mass displacement because these corporations are just god awful and wouldn't give you a second chance, and would they lay off 1 million people out of spite? Probably. But at the same time, it's that, you know, giving that prioritization that's written in CalCare, which we would get prioritized into this health system. You know, so I would go and be a director or a manager for CalCare, you know, maybe a regional or something like that of that sort. It's very much so possible. Like I said, no one's going to know what it looks like because we're the first to do this in our country. We're the very, very first. So a lot of these questions, people want to know, what does it look like? What does it look like? Well, guess what? If we would have had a more morally just country, we probably would know what this looks like, but we don't. So we've got to be the first ones to do it. But, you know, coming from someone that I know that I could potentially and very well would probably lose my job because my company would not hesitate to cut. I know that I'm doing the right thing, and this is the right thing because millions of people will get help. And I'm putting my money where my mouth is and saying, yeah, I'll throw away my 6-figure job to push this right now.
I think too, if you don't mind me jumping in here, you know, this was written by the nurses, and they are a labor union. So, and they also wrote SB 562, and there was so much talk about taking care of, it wasn't the executive positions, but the laborers that work for insurance companies, to make sure that they were taken care of. Just like the Green New Deal, people, you know, talk about taking care of those, you know, who work in the coal mines and making sure that they have the green energy jobs. So I think that definitely the intention is to find placement for workers, but it's a great question. So moving on to the next question. How will a resident be defined?
Yeah, no, so it's a time length. I think it's 90 days, but if my memory is faulty and somebody could correct that. But I should say that's actually the type of issue which California has a lot of experience in determining who's a resident of the state, for a whole bunch of different reasons. For example, for, you know, what tuition you pay if you go to one of the universities or things like that. So there have been mechanisms for that, but just somebody else, if they saw it, I think it's 90 days. I think once you're in the state for 90 days, you're set. And there are people who might continue to say they work for some firm out of state but are living in California. And there's sort of some anticipation of people who are sort of interesting categories like that.
So I see this in the
Oh, you're muted or something.
Yeah, she froze again. She's freezing every once in a while.
Well, I mean, I see that maybe in the chat there's Betty's question about portability, which is it does anticipate that the state would have a responsibility.
Chat from Betty, and it did remind me.
You're in and out.
You're in and out. It's
Yep,
funny.
I'm back. Did you, take Betty's question about portability, and was talking about this with Bronwyn a while back, and she was saying, what if you're a California resident and you travel to a different state and you get hurt, then what?
Yeah, California is still your insurance company. Like, and that can be an issue, by the way, at times with actual insurance, with commercial insurance, what I mean. But this is pretty clear that there would be a mechanism for the state to pay out-of-state providers when for specific reasons like that. One thing I know we're getting close to the end, and actually I wanted to say something or sort of that maybe might be slightly different in the office hours model, which is, people ask some really good questions, and then I answered them, and I hope you like some of the answers. And I mean, I really like Jeanna's answers. I hope you like some of the answers, but you may have said, wait, there's something else that you did. No, I don't buy what you just said, or that didn't seem right, or whatever. And I do think that we envision it not just being like question, answer, and, that there be back and forth on things, because follow-up questions are often very important for activists, for government, for legislative stuff.
Yeah, so really this is, we're very excited to have our office hours coming up. I believe the kickoff date you said was March 28th. It's going to be from 5 p.m. to 6 p.m. Did I get that right, Ron?
Right.
And so it'll be on Zoom. It will not be Facebook Live. So it'll be more of a private setting. And as soon as we'll be putting out that Zoom link soon, we'll put it out on our social media. And so, but we want to invite, like, I'm looking at Dr. Sarah Dean up in the Zoom. We're not just inviting people to come and ask questions, but come and help lead, because we know that you've been doing presentations. So the invitation, is out there. If you've read the bill, come and participate in the office hours. To help answer questions, to ask questions, bring CalCare haters. We welcome them. We would love to have them attend office hours. It can also be used, I keep calling it a study jam, but my life gets really busy with the kids and everything, and I might just use it as, I have a meeting from 5 to 6. I might show up on Zoom, say, hey, y'all, I'm here. I'm going to mute myself, and just use it as a time to read the bill and be like, I got through paragraph number 5. So it's all in support of, becoming educated about CalCare, so that we understand it, so we can go out and talk about it. And we're super excited to have this starting up. I think it's next Sunday. And like Ron said, it's going to be more of a discussion. It's not just question answer. You can debate Ron and Jeanna, or whoever our leaders are. So with that, we are closing. There is another announcement. I think I'm going to let